Okay, we're gonna start with chapter 11. We're gonna do shock. I'm working with both some flashcards that I made and some notes. So to start out, what is shock? I don't know. It may lead to MODS, which is, if I remember correctly, because I didn't write it down, multi-organ dysfunction syndrome, which can mainly happen with septic shock. We'll get more into that later. Basically what shock is it's an inadequate tissue perfusion, which leads to an imbalance of oxygen and nutrients that are being delivered and perfused to all the organs and tissues in the body, right? So there are three things that you need to essentially like have a successful working system so you don't lead into shock. So you need effective cardiac pump, which is your heart. You need an effective circulatory system, so like everything moving through. And you need an effective amount of blood volume. So if any one of those three things is not working or is dysregulated, this is what can potentially lead you into shock, right? So if your heart stops working, cardiogenic shock. If you don't have enough blood volume, hypovolemic shock, right? Some common responses between, no matter what type of shock you have, it doesn't matter. Some things that you might see in the patient: 1, hypoperfusion; 2, hypermetabolism; and 3, an inflammatory response. Again, it doesn't matter. Those can happen in any types of shock, right? Some pathophysiology is that your body normally uses what's called aerobic metabolism, basically just to say that it uses oxygen. So when your body isn't getting the oxygen that it needs, it converts and it starts using what's called anaerobic metabolism. And basically this is a problem because it's using metabolism without the oxygen. So it leads to increased lactic acid levels, and this eventually leads to cell death because they're not getting that oxygen that they need, right? Your liver starts doing, it's called glycogenolysis, and it basically is converting like proteins and fats into glucose for ATP for the body to use. And that's not normal. This is like, we're freaking out, I don't have oxygen, I need ATP, I'm gonna pull it from somewhere, right? So it starts pulling it from protein, from fats, where it normally wouldn't, so that, you know, your body can have the energy that it needs. Again, leading to cell death. It also can lead to a lot of clotting, which is not good. Yeah. And then I kind of just wrote down the MAP, the mean arterial pressure, is calculated cardiac output times peripheral resistance. Your MAP must be over 65 for your organs and your tissues to be adequately perfusing, for everything to be getting the oxygen and everything, like the nutrients that they need. If it's not over 65, that means your organs and everything aren't getting what they need, right? Want it over 65. Some signs of shock in the older adult, it looks a little bit different than it would in like a younger aged person. They might be, if they're on medications like beta blockers, ACE inhibitors, whatever, it is probably hiding that elevated heart rate that we see is like one of the first like stages of shock. So some medications that they might be on might be hiding that stage, so, or that, you know, that tachycardia, so you need to be aware of that. They might have a lowered temperature, or their temperature might be rising very slowly. Just kind of monitor their temperature. If it's anything outside of their baseline, that's kind of like an issue that you should address. The patient may report just feeling tired or lethargic. They might develop arrhythmias if it's like cardiogenic shock, and they might have an altered mental status. That's always like one of the first things for everyone too, is altered mental status is not a good thing, right? All right, I'm gonna quit on the flashcards for a little bit and then go to some notes. We're gonna start, there's 3 stages. We're gonna start with the compensatory stage. Compensatory stage is we'll have a normal blood pressure, that's fine, but we'll have that tachycardia like I mentioned, right? We have some vasoconstriction going on, which is what's causing the heart rate to rise. We'll have increased contractility, and the body starts to release the catecholamines. So natural epinephrine, norepinephrine, again, that's what's raising the heart rate, right? Blood is going to start being shunted only to your vital organs, so like really to your lungs, to your heart, things like to your brain, But like kidneys and your liver and things like that, they're not going to get the blood. So essentially what's going to happen is you're going to see a decrease in those kind of things. So you'll see a decrease in urine output, confusion, agitation, hypoactive bowel sounds. They're pale. Their skin will be pale and cool. They will be in a respiratory alkalosis. So they'll be probably hyperventilating. They'll have a respiratory rate over 22. Just some general nursing, which we'll get more into later, is know to correct the underlying disease, whether it be cardiogenic, anaphylactic, neurogenic, whatever. A lot of the times, generally, it's going to be fluids, oxygen, medications, and knowing the labs and how to correct the labs, which it really depends on what kind of shock it is, right? So we're just talking about the compensatory stage, knowing what's going on, seeing what's going on, and trying to correct what's going on. Observe their level of consciousness, their vitals, urine output, and their skin. Things that you should report. If you notice this, you need to let the doctor know. If their systolic blood pressure falls under 100, report that. If their systolic blood pressure falls 40 from their baseline, so like let's say they're sitting at 180 constantly, right? And you go and you check it and it's 130. You're like, oh, it's over 100, it's not fine. That's not fine, because that's 50 from their baseline. That's not fine. You need to report that. If their MAP is under 65, again, if their respiratory rate starts going over 22, they're like really hyperventilating, you need to report that. And any change in mental status needs to be reported as well. Keep in mind their pulse pressure. A normal pulse pressure, remember, that's the systolic minus diastolic. A normal pulse pressure is between 30 and 40. If it's narrowing, that's an early indicator of shock. So if you notice the pulse pressure is like anything under 30, really, I would call the doctor. I would report that. It's important to know that the PP dropping is actually a late indicator. Remember, because in the compensatory stage, it's normal. So if the blood pressure is dropping, you miss the signs. So it says at this point, you need to start clarifying some advanced directives, asking the patient, heaven forbid something happened, what do you want us to do? How do you want us to handle any like end of life choices, decisions, whatever. Frequent reorientation, hourly rounding, making sure that we're preventing the patient from injury, especially if they're confused, bed alarms, things like that. Always, always, always safety and prevent injury. Okay, so that's the compensatory stage. So, assuming we missed all the signs and we did nothing, now our patient is leading into the progressive stage, right? So now we start to see that drop in blood pressure with the systolic dropping under 100, MAP under 65. No matter what type of shock it is, whether it be cardiogenic, neurogenic, anaphylactic, whatever, the heart will fail first. That is always the first organ that gets screwed over, right? So in the stage and progressive stage, even if you do correct the underlying cause, the patient is still in this vicious cycle that it is really hard to get them out of, right? Like we're progressing, not in the good way. So some manifestations of progressive shock are rapid, shallow respiratory rate with crackles, because now they have probably pulmonary edema going on. Yeah, they sure do. I put acute lung injury or acute respiratory distress syndrome. Some cardiac things that you might see, heart rate is now elevated crazy. Before, in our compensatory stage, it was probably just a little over 100. Now in our progressive stage, it's over 150. Like, it's crazy. It's really trying really, really hard to pump out some blood and perfuse our organs and everything, right? It's trying. Patient might have an MI. They'll definitely have some elevated biomarkers, the cardiac biomarkers, so like the troponin, the TNT, things like that. In this stage, the patient will be seen a lot more lethargic, and they might have a complete loss of consciousness. Looking at their kidneys, they will have acute kidney injury, so increased BUN creatinine, decreased urinary output. Liver, I'm scared. Liver is going to be a little screwed up, so you'll have elevated liver enzymes like the AST, the ALT, elevated bilirubin levels. In the GI, you might see, they'll have ischemia, so they might have bloody diarrhea, decreased metabolism, and metabolic acidosis. So remember, when we're looking at our ABGs in that first compensatory stage, we had their respiratory alkalosis where they're hyperventilating, and now we'll have the kidneys trying to like compensate almost. So they will actually be metabolic acidosis, okay? They might have DIC, disseminated intravascular coagulation. Look at their PT and APTT, they'll be prolonged. They might have modeling and the petechiae from the DIC, right? Their cap refill will be over 3.5 seconds because they're not getting perfused. They're not getting any blood, no oxygen, nothing. So some nursing interventions that we can do while our patient is in this stage, in the progressive stage, is with insulin therapy, we really just want to keep the blood glucose under 180. Do not try and really worry about making it, you know, between like 70 and 100. That's not, like, they actually need some glucose right now, so it's okay to let it be a little bit higher, right? So let the serum glucose, as long as it's under 180, we're good. Definitely worry and focus a lot on that respiratory. We want antacids, H2 blockers, because they might get like peptic ulcers and things like that. Yeah, I wrote antipeptics. We want to prevent infections and VAP. So I believe in this stage, this is when they're getting mechanically ventilated and intubated. So, you know, to prevent VAP, the ventilator acquired pneumonia, we talked about this in class. Oral care, turning, elevate the head of the bed 30 degrees, provide them the sedation vacations. We want to promote rest and comfort in this patient. So if they're sleeping, do not interrupt them. Let them sleep. Oh my God, let them, they need it, right? I also wrote too, you want to like obviously support the family, let them know what's going on, let the patient know what's going on. And always remember too, if the patient is unconscious, you still need to let them know. You know what I'm saying? Still talk to them, still keep them updated, even if they're not responsive. It's still important to keep patient and family and everyone updated and involved. So if we're doing fluid replacement, we have some complications. We can have cardiovascular overload. We can give them pulmonary edema. So we want to monitor urinary output, their mentation, their skin, their vitals, auscultate their lungs, assess for the edema, have continuous pulse ox on them to see if like any of the therapies or anything are working, or if it's getting worse, if it's getting better. And then I wrote prevent CLABSI, C note card, but I don't need a C note card because I already know what to do. So CLABSI, central line associated bacterial something infection, right? Associated infection, whatever. So central lines, obviously we talked about this, so you already know you better keep it clean. Hand hygiene, sterile. It's sterile. It's a sterile procedure. So always, you know what I'm saying. We want to prevent infections. Infections that can lead to sepsis. So prevent infections is really, really, really important. With our ventilators and the lines and everything if they're so okay, so we're gonna get into some vasoactive medications. So this can include like inotropic vasodilators and vasopressors. We'll get into it. So vasoactive medications are given in every single form of shock. What it is, it just depends on the shock. We have alpha adrenergic blockers, which like constrict. We have beta 1 adrenergic, which will increase the heart rate. Beta 2, which will vasodilate. It's important to monitor the patient's vitals every 15 minutes, okay? These vasoactive medications are given through a central line. That's really important, right? They're given through a central line. I believe it's because they are, a lot of them are, what's the word? Toxic? That's not the word. I can't remember. Like if they infiltrate or what have you, they're like vesicants, right? They're really dangerous and really harmful. What's up, Ho?
Yellow.